to be our second. This is going to be our second installment of our monthly educational webinars. Um, um, just as a quick point, this meeting will be recorded. And if you have any questions during the presentation, please add them to the chat and we can discuss them after the presentation is finished. The topic of today's presentation is going to be the management of lower extremity wounds, emphasizing the significance of appropriate testing. I have no disclosures to state. If you guys want to read the disclaimers, I can leave them up for a second, or we can review them after the presentation. The objectives of today's presentation is the lower extremity assessment, discussing how to do an assessment for the lower extremities, the different types of lower extremity wounds. We're going to talk about ABI and TBI testing and the management of venous, arterial, and diabetic ulcers. And finally, we'll talk about the services that we offer at ProHealth One. So some facts about lower extremity wounds. In the United States, lower extremity wounds affect about 13% of the population. That is over 40 million people. Healthcare costs to treat lower extremity wounds are about $20 billion a year. Critical limb ischemia, aka arterial obstruction, causes about 75,000 major amputations and about 134,000 minor amputations a year. 70% of patients who have major amputations will die within 5 years. So the first part of assessing lower extremity wounds, as in any assessment, we'll obtain a medical history. In doing so, we're going to try to pay particular attention to the following risk factors that increase the incidence of lower extremity wounds. So obesity, trauma, malignancy, aging, pressure, poor nutritional status, autoimmune conditions such as pyoderma, pemphigus, atherosclerotic disease, Berger's disease, which is also known as thromboangiitis obliterans. And it's a rare condition that causes clotting in the small and medium-sized arteries in the fingers and toes, which is very strongly associated with smoking. Peripheral artery disease can also cause, as a risk factor for lower extremity wounds, pregnancy, heart failure, varicose veins, fractures, DVTs, clotting disorders such as factor V laden, high blood pressure, sickle cell disease, vasculitis, and vascular insufficiency. The big four for lower extremity wounds are going to be smoking, diabetes, venous hypertension, and hyperlipidemia. As part of our health history, questions we want to ask patients and try to get more information about is if the person is experiencing any rest pain or claudication or any nocturnal pain. Does the patient have a wheelchair? How do they ambulate? Do they have any issues with ambulation? We also want to know, not only look at the limb that might have a wound, we want to compare with the contralateral limb. We also want to look at the color and temperature of both limbs. We want to ask how long has the ulcer been present, or any precipitating or alleviating factors that make ulcers get better or worse, or the pain get better or worse. We also want to know, obviously, history of surgery, trauma, and ulcerations of lower extremity and feet in the past, and any pre-existing medical conditions, diabetes, or the other risk factors that I mentioned previously. And also smoking is a big thing we want to know about.
Calling Nicole Coates, iPhone.
In assessing the lower extremities during the physical exam part of the assessment, we're going to visually inspect the limb. We're going to look for hemosiderin staining. We're going to look for rubral dependency, edema, pigmentation, scarring. We're going to assess the circulation, which I'll go into detail on the next slide. That includes checking peripheral pulses. We're going to check for skin texture. We're going to assess dryness, hair distribution, check for calluses or corns, any surgical scars, bone deformities, skin turgor or varicosities. In particular, I mentioned this a lot during rounds, I'll mention trophic changes. And this in particular is seen in patients with peripheral artery disease And it includes having dry, shiny skin and hairless skin. It also includes fissuring between the toes and hypertrophic males, as you can see in the picture on the right. The picture on the left shows some hemosiderin stain in a patient with longstanding venous leg ulcers. As for circulation, during the physical exam, we're going to check capillary refill. Capillary refill, basically you're going to gently press on the distal end of the patient's toes or on the nail bed for about 2 to 3 seconds, and then you're going to release the pressure. And a normal exam would give you the distal part of the toe is going to become about less than 3 seconds. If this is more than 3 seconds, that is an abnormal exam, and it means that the patient has decreased circulation. For the Berger test, this is a 2-part exam. You're basically going to have the patient lay supine, and you're going to slowly lift their leg to about 45-degree angle. You're going to pay attention to the plantar aspect of their foot and the tip of their toes. That's the bottom of their foot. And an abnormal test, and you're going to hold it there for about 90 seconds to 2 minutes. In a normal test, a patient without any issues with circulation or peripheral artery disease, you're going to, the bottom of the foot's going to stay pink and the tip of the toes. In a patient with decreased circulation, arterial insufficiency, the plantar aspect of the foot's going to turn pale. You're going to try this as if you reach 45-degree angle, you can try it at lesser angles and see which is the angle where the patient starts to, the bottom of the foot starts to become pale, and that's what's called the Berger angle or the vascular angle. The second part of the test, you're going to dangle a leg at the side of the table, 90 degrees in a dependent position, and you're going to see how long it takes for the limb or for the foot to turn pink again. In a normal test, this will be less than 50 seconds. On a normal test, it'll be more than 30 seconds. And between that transition of pale to pink, there's going to be a deep rubor color, which is also called the sunset color. In addition, we will palpate the lower extremity pulses, so femoral pulse inside the groin, popliteal pulse behind the knee. These sometimes can be difficult to palpate in obese patients. In particular, in the presentation, if I mentioned ankle pulses, this is reference to the dorsalis pedis and posterior tibial artery pulses. Dorsalis pedis just above the foot, in the dorsal aspect of the foot, and the posterior tibial is on the medial side of the ankle, just posterior to the medial malleolus. In assessing for skin temperature, we're going to start at the proximal aspect of the leg, and we're going to move distally. We're going to check the temperature of the leg, basically by placing our hand on the leg with the palmar surface of the hand and fingers, and gently sliding down. If you notice any sudden marked changes in temperature from proximal to distal, such as the thigh compared to the shin or calf to foot, then this can be an indicator of lower extremity arterial disease. The opposite end, if you sense a change where there's higher temperature at the ankle, let's say compared to the thigh, then this can be an indicator of lower extremity venous disease. If there's inflammation present, there can be an elevation in temperature of approximately 2.2 degrees Celsius. And it can be done also with a handheld thermometer, one of those laser thermometers that became popular during the pandemic. For edema assessment, there's essentially 2 types of edema. There's pitting edema and non-pitting edema. Pitting edema, we usually talk about +2 pitting edema or +3 pitting edema. The edema is said to be pitting when you gently put some pressure on the skin and there's an indentation that does not rapidly return to the normal body contour. And in general, the difference between +1, +2, and +3 pitting edema can be a time that it takes from the moment you do the indentation to the moment that it returns to normal body contour. Non-pitting edema, as is seen in lymphedema, there's no visible indentation after pressure is applied. The skin is usually firm and tight. Other tests that we can do during the physical exam is functional tests. We can have the patient walk, so observe their gait. We can test for balance. We can see how quickly a patient can put on or take off their socks and shoes. We can see if the patient knows how to needs walking aids or knows how to use them. And we're going to basically assess for any impairments in ambulation. So for sensory testing, we can test for temperature, as we've discussed. We can check for pain. We can check for pressure, vibration, proprioception, and friction. With regard to sensory testing, a particular test that that is recommended to be done at least once a year in type 2 diabetics and at least once a year in type 1 diabetics that have been diagnosed with type 1 diabetes for at least 5 or more years is the Semmes-Weinstein monofilament test. Basically, you take a 5.07 Semmes-Weinstein monofilament test, and you're going to place it on different parts of the bottom of the foot, on the plantar aspect of the foot. And this is going to test for protective sensation. We usually test about 10 different spots on the plantar aspect of the foot. It's called the 10-gram monofilament test because you're supposed to apply about 10 grams of force, which is essentially the amount that requires for the monofilament to bend. And the areas that we test is essentially the plantar aspect, the first, third, and fifth metatarsal head, the heel, the lateral medial arch, the plantar aspect of the first, third, and fifth toe, and the dorsal web spaces of the first and second toe. During this test, you should make sure that the patient's eyes are closed and that you vary the timing between the different areas. Other tests that we could do is the pinprick test, tuning fork, temperature, as I've talked about. And these tests can predict future risk for complications while testing for the presence of any dysfunction. So with regards to lower extremity wounds, patients can have many different types of wounds in the lower extremities: skin tears, abrasions, lacerations, malignancies, autoimmune conditions. In particular, for the patient population that I treat the most, geriatric patients in the post-acute setting, these are the big three that I see the most in lower extremities, with venous leg ulcers being by far the most common in this patient population. So for venous leg ulcers in the leftmost column, predisposing factors for these wounds are going to be a history of DVT, stroke, obesity, pregnancy, or advanced age. These are commonly described to occur in the gator region of the lower extremity. So that would be the medial lower leg or the malleolar region. These wounds tend to be irregular. So they have irregular wound margins, not symmetrical as other wounds. They're usually superficial and they have moderate to heavy amounts of exudate. They tend to be very painful, but some patients can describe them as painless. Pulses are usually palpable unless there's significant edema that may not allow you to assess that during the physical exam. And skin changes that you'll see in these ulcers it's going to be edema, hemosiderin staining, stasis dermatitis, which is essentially the same thing, and you're going to see dilated superficial veins or varicose veins. As for arterial ulcers, risk factors are going to be smoking, advanced age, peripheral artery disease, diabetes. These tend to occur between the toes or on the tips of the toes, in the lateral aspect of the leg, or the malleoli, or the foot, and over the phalangeal heads. These are, as opposed to the venous ulcers, these are usually round, they're dry, they have even wound margins. There's usually dry eschar, and there's minimal or no exudate at all. They're usually very painful. Pulses are usually absent or diminished, and skin changes that you'll notice in these types of ulcers. You're going to notice cyanosis. There's going to be decreased temperature or cool skin or cool temperature in the skin. You're going to notice thick toenails, as I mentioned. So those trophic changes, hair loss, and pale and dry skin. Diabetic foot ulcers. So these are going to be seen in patients with diabetes that have peripheral sensory neuropathy. The location is usually going to be the plantar foot, the metatarsal heads under the heels or toes, but essentially it's any ulcer in a patient with diabetes and neuropathy that below the level of the malleoli on the foot. The appearance. These are going to have even wound margin, callus formations, as you can see in the picture, and there's also going to be low to moderate exudate. Usually these are painless due to the sensory neuropathy. Pulses are variable depending on the severity of arterial insufficiency, and skin changes. You're going to see the callus around the ulcer. You could see a warm foot if you have Charcot's arthropathy, and you also see some deformities, like so there's Charcot's foot or claw toes. So how do we know if a wound on the foot is a pressure, diabetic, or vascular? So this picture. So this patient has poor circulation and has serious diabetes. Patient wears shoes that are ill-fitting and rub consistently on the same area. Would you say that this is considered pressure injury? No. Is this considered a diabetic foot ulcer? Yes. This picture shows the classic presentation of the diabetic foot ulcer on the foot below the level of the malleoli with clear textbook callus ring around the ulcer with little to no exudate. So again, this picture is the picture of a patient I treated some time ago. He had a TMA amputation, and then he slowly developed a diabetic foot ulcer where you can see the callus around the edges of the wound. People with diabetes can develop many different foot problems due to the poor circulation, which makes the patient less able to fight infections and heal. And the diabetes also causes the blood vessels in the foot to calcify and harden. There are many mechanisms that not only cause wounds in diabetic patients, but that also are occurring simultaneously that prevent them from healing effectively. To be classified as a diabetic ulcer, the patient has to have a diagnosis of diabetes. And as I mentioned, diabetic ulcers are present on the most commonly in the plantar aspect of the foot, under the heels, and over the metatarsal heads. But by definition, any ulcer below the level of the malleoli in a patient with diabetes and neuropathy. So based on the assessment of a wound, what would be a proper diagnostic tool that we could look at to determine not only the etiology of the wound, but the healing potential, proper interventions, and treatments? So that would be the ankle brachial index, or ABI. This is a gold standard diagnostic test that can be used to determine the type of wound in the lower extremity. It's a simple test that can be done in the wards, at home, in the bedside, in the nursing home, or even in the clinic. And the test is basically going to compare the difference in the pressure, in the systolic pressure, or blood pressure, of the upper extremity and the lower extremity. And basically, the test can be used as a screening tool to determine whether the patient has any arterial insufficiency, the severity of that insufficiency, and we usually use it as well to screen before doing any type of compression therapy in a patient with venous leg ulcers. So again, the ankle brachial index, we recommend that in our patient population, particularly in the geriatric long-term care setting, we recommend that any patient with a lower extremity wound should undergo this test. Basically, all you need is a sphygmomanometer and a handheld Doppler, and we're basically going to take the ratio of the ankle pressure, which is either the dorsalis pedis or posterior tibial artery systolic pressure, and divided by the brachial systolic pressure. Other reasons that you could order an ABI test is to assess the symptoms of the peripheral artery disease, to diagnose peripheral artery disease, so as a screening tool. As I said, to assess the severity. Following surgery, it could be used to kind of monitor for any decrease in blood flow following surgery in the lower extremity. You can also use it as a screening tool for coronary artery disease, to see if there's a risk for having a heart attack. And you can use it as to stratify the risk of having a future cardiovascular event such as stroke or heart attack. So the normal value that we want to see is an ABI above 8, which this would allow us to use compression therapy in a patient with venous leg ulcers. A value of 0.9 is going to indicate that they have normal arterial flow. So the Wound Ostomy Incontinence Nurse Society recommends that patients with lower extremity arterial disease and non-healing wounds, that you should perform ABIs on them every 3 months. And the reasoning they say is that this will help identify patients that are at risk of developing critical limb ischemia. So it can help you essentially see if the disease is progressing. Because if you identify that early, then a change of care, you can change plan, seek referral, and hopefully save a limb. So these are the results and how we interpret them for the ABIs. So as I said, it's the ratio of the ankle pressure over the brachial pressure, upper extremity pressure. So the normal value that we want to see would be a value between 0.9 and 1.3. Anything above 1.3, that would indicate that the ankle pressures are very high, and that is an unreliable result, and that renders the test invalid essentially. And this is usually seen in patients with long-standing history of uncontrolled diabetes, and the arteries become calcified, so they're not compressible. A value less than 0.9 is diagnostic for arterial insufficient peripheral artery disease. The lower the value goes, the more severe the disease, and you can actually correlate these values with symptomatology. So values between 0.8 and 0.6 can indicate a patient with claudication. Essentially, when they ambulate after a certain point, they start to develop pain in their calf muscles or in their thigh muscles. The blockage is not allowing those muscle cells to receive oxygen and nutrients. And then patients with values between 0.6 and 0.4 or lower usually will show as rest claudication. So essentially have pain in those muscles in their legs at all times. So as I mentioned, an ABI greater than 1.3 is unreliable or a false negative, or it can be a false negative due to the calcification of the inner layer of or the medial layer of the arteries in these patients. And these vessels are then non-compressible, and then they become inelastic, and the value is going to be basically elevated. In these patients, we recommend getting a TBI or a toe brachial index, because the ankle brachial index may give you a false negative value. So the toe brachial index is essentially the toe pressure divided by the brachial pressure, and it's an alternative to the ankle brachial index. Also a non-invasive test. You can see in the picture the machine that Wendy or MA that does these tests utilizes. And it mentions the ratio of the toe pressure and the brachial pressure. This index is less affected by arterial calcification, and it has a better diagnostic accuracy, especially for diabetics. So for the toe brachial index, normal values are going to be those above 0.7. Anything less than 0.6 is going to warrant further evaluation and testing. Values less than 0.7 to 0.6 are strongly associated with lower extremity arterial disease, and values less than 0.6 are going to prompt urgent vascular referrals. So if I were to describe with one word the treatment for venous leg ulcers, it's going to be compression therapy. So compression therapy can be safe to perform on patients with ABIs above 0.8. It can also reduce the risk of blood clotting, can treat and prevent edema, improves venous flow, maximizes the transfer of oxygen and nutrients in the skin, and reduces the occurrence of infection. Compression therapy supports wound healing and assists the veins to move the blood back up from the legs to the heart. So indications for compression therapy are lower extremity vascular disease, and it's basically the gold standard for managing patients with venous ulcer, and it can also help treat edema. And essentially, we screen all these patients with ABIs before beginning compression therapy. Safe to use in patients with ABIs above 0.8. However, the lower the ABI value, the less compression we want to apply. So contraindications to compression therapy. So patients that have ABIs less than 0.5, as this can cause basically ulcerations in the distal part of the limb and the toes and the foot. Patients that have untreated acute DVTs, patients that have decompensated congestive heart failure, as this can essentially push all that fluid back into their heart and send them into worsen their heart failure. Ankle pressure is less than 70 millimeters of mercury. Toe pressure is less than 50 millimeters of mercury. Patients that have a history of having pain with compression, Me personally, I don't do compression therapy until I screen them with ABIs or have documented history of a recent vascular study being performed. In addition, you should use compression cautiously on patients with a history of peripheral artery disease, decreased sensation, infection, or any allergy to the material using the compression. The frequency, so you can technically leave them in place for up to 7 days. The order we'll usually write is change weekly appearance for soiling, dislodgement, or saturation. Sometimes I'll just have them kind of overlay them again with another Curlex gauze if they're striking through. But for the most part, you want to change them up to 7 days. If you see a lot of strike through or the patient's complaining, you can change them more frequently. Also, throughout the day, if the patient has a lot of edema, maybe in the morning it's not so severe, but later in the afternoon, as they're sitting in their chair, it might become more severe. So that's also might be an indication to adjust the wrap. And also sometimes, depending on the expertise of the person wrapping them and patient factors, these can slip or become unwrapped throughout the day or week. And you should always refer to manufacturer instructions. So compression hosiery and compression bandages are two different types of terms. Hosiery, we usually use it for prevention of ulceration, of venous leg ulcers, whereas the bandaging is actually used, which are the actual wraps, are actually used during an active ulcer. Like I mentioned, the lower the ABI results, the less compression can be applied. And the goal is to achieve that perfect therapeutic level of compression for the particular patient and their ulcers. You can use higher levels, so 30 to 40 millimeters of mercury. And this sub-bandage pressure is usually measured at the ankle. And you can use this freely when the ABI is above 0.8. As I mentioned, the lower the ABI, the less millimeters of mercury or sub-bandage pressure you should apply. So findings. So current evidence shows that the use of multi-component bandages is better than single-use bandages, so single layers. The 4-layer compression bandage appears to have the same performance as 2-layer compression bandages. Patients who receive 4-layer compression bandages appear to heal faster than those who receive short stretch compression system, and I'll explain that in a minute. And patients have better healing rates with high compression stockings that were short stretch bandages. Essentially, you want to, so some compression is better than none. You want to start up low or slow and work your way up. Inelastic compression applications have significant effects on the deep venous system compared with just elastic bandages. And the dosage and the stiffness of different kits, and there's many, many different types of kits, they differ between kits. So essentially, we have here two groups. So there's elastic bandages or long stretch bandages, and there's inelastic or short stretch bandages. So the long stretch bandages is usually used when the extremity is at rest and it produces external pressure into the venous system. When the extremity is active or the muscle expands, the product continues to exert external pressure, and it is used primarily in patients who are sedentary, and it can adapt to changes in volume. As the leg swells, the bandage can accommodate that swelling. Short stretch bandages, there's very little pressure that's exerted when the extremity is at rest. However, when the patient's ambulating, it essentially aids the calf muscle in the contraction and pushes fluid out of the leg, and mostly used in patients who are ambulatory. So examples of long stretch bandages are going to be your Cobands or ACE wraps. You might hear those terms. Long stretch reusable wraps. With regards to short stretch bandages, there are the Una boots or Duke boots or single-use wrap. Curlex gauze is also considered a short stretch bandage. I was actually taught this in 3 groups. So long stretch, short stretch, and no stretch. So technically the Una boots are no stretch. And basically the way you can tell easily during rounds is long stretch, you can stretch it to 1, 2, 3 times its length. Short stretch, you can only pretty much stretch it to about 60%, and no stretch, you can stretch it at all. So tips for applying compression therapy. You should apply it from the base. So how it's described is 2 fingers press, 2 fingers below the metatarsal MTP joint to above the tibial tuberosity. So just below the knee. So just below the toes to just below the knee. You should apply it in the morning before the patient gets out of bed. You should ensure that the patient's foot is in dorsiflexion during wrapping. You should moisturize the peri-wound. You should avoid any pleats, folds, or wrinkles especially in the plantar aspect of the foot. Obviously, during the wrapping and after, assess for any pain, numbness, or tingling. You should monitor for any skin breakdown around the wrap, and when changing the wrap, you should definitely screen for peripheral artery disease with ABIs before applying any compression wrap. And you can consider using cotton padding to prevent friction and pressure damage, especially around the malleoli. And when you're wrapping, you're going to use a spiral wrap technique or a figure-of-8 technique. So on the right is a picture of an example of an Una boot. We use this all the time during rounds. So Una boots or paste wrap. It's inelastic, so no stretch, gauze dressing that's saturated with calamine, glycerin, or zinc. It becomes rigid when it dries, not as much as a cast, but it becomes semi-rigid. And it does not apply compression, but basically restricts the leg from expanding, or it restricts the leg from swelling. It should be changed if it becomes saturated, loosened, or slipped. You can leave it up to 7 days, and you can even apply it directly over a wound, although sometimes I'll add another treatment or a primary dressing over this wound and then apply the Una boot, but that depends on the wound of the patient, and they're pretty inexpensive. So paste wraps, so the main benefit is that semi-rigid support, and it basically augments the calf muscles function. They describe it as having high working pressure, but it doesn't provide any compression per se when the patient's at rest, but it does prevent the leg from swelling. These are most appropriately used for patients who are ambulatory. I'll sometimes use it in patients who like to sit in their wheelchair for the majority of the day, and their leg kind of swells and ulcerates throughout the day. And this can prevent the leg from essentially swelling. I usually won't add additional layers depending on their degree of peripheral artery disease or arterial insufficiency. But yes, it's usually not recommended for wheelchair bed-bound patients. So paste wraps or Duke boots, which I use all the time. We do all the time during rounds. Essentially, is an Una boot, and then a self-adherent wrap such as Coban. And I'll usually add a middle layer, such as a gauze or Curlex wrap. So Una boot, Curlex, and Coban, and it provides moderate compression with ambulation. And you can leave it in place up to 7 days. So as opposed to the compression wraps, which we've been talking about, compression stockings or the hosiery, they are usually used after the wounds heal or to prevent wounds from forming. Pros is that they're reusable, they're comfortable, they come in various styles, colors, and sizes, and they promote compression for life. Cons, they're expensive. If you were to have them custom made, they're difficult to apply. Difficult to apply over wound dressing. That's why I usually don't recommend them when there's an active ulcer. And then as the edema resolves, the compression is going to be reduced. And then if you wash them too frequently, it can shorten the lifespan of the compression stocking. Application for the stockings or the hosiery, you should apply them before getting out of bed. There's commercial devices that can aid in application. You should replace them every 3 to 4 months. And you can use rubber gloves. It'll make it a little easier for the application. And you should encourage the patient to shower in the evening after the stockings have been worn for the majority of the day. So TED stockings or thromboembolic deterrent stockings, they provide compression levels less than 20 millimeters of mercury. They're appropriate for non-ambulatory or bedridden patients. They support lymphatic and venous drainage. They provide majority of the compression at the calf muscle, and they're basically used for VT, venous thromboembolism prophylaxis. So with regards to arterial ulcers, if I were to say with one word what the treatment is, it's revascularization. So the primary focus basically is to increase the perfusion of the limb and prevent infections. Essentially, a wound will not heal if there's not sufficient oxygen and nutrients. These wounds it is advised that you do not debride them, especially sharp debridement, as this can cause further injury, as there's no blood flow to heal if you were to kind of affect intact wound, the peri wound, which is intact. As the picture shows, that's essentially dry eschar, dry gangrene, and you want to keep this dry. You do want to monitor closely for any advancements of that gangrene or expansion. And essentially, the treatment you should refer these for revascularization or amputations, as these are options in the patients with arterial ulcers, since this disease does tend to progress. These patients should not get compression therapy, as this may cause furthering of these wounds, limb ischemia, and may lead to amputations. But it's important to mention that you should not debride arterial ulcers. As for diabetic foot ulcers, if I were to describe it one word, the treatment for these wounds is offloading. So for management of diabetic foot ulcers, you're going to address the underlying disease process. So you're going to manage the diabetes. You're going to screen them for arterial insufficiency with ABIs. If there's infection present in the ulcer, you're going to treat that. Debride if it needs to be done. But the most important thing is to offload the affected limb. The less steps the patient takes with the affected limb, the quicker these wounds will heal. So in diabetic foot ulcers, you'll see us frequently debriding these wounds on a weekly basis. All non-viable tissue should be thoroughly debrided till you get to a bleeding wound bed. And you're going to debride as deep as needed. These patients with diabetes and sensory neuropathy tend to develop calluses on the plantar aspect of their foot. So you should excise these regularly. And it is well documented in the literature that less frequent debridements can affect healing rates negatively. That devitalized tissue, the slough, eschar, needs to be removed in order for that wound to progress through the stages of wound healing and eventually heal. In patients with arterial ulcer and sometimes with patients with diabetic foot ulcers, you'll see what's called dry gangrene or dry eschar. That you should essentially do not debride that. That should be essentially left alone. If it were to become wet eschar, wet gangrene with drainage, that means it has become infected. And then that's an indication for further surgical referral. So the gold standard for diabetic foot ulcers, in particular Wagner 2, which is essentially a deep ulcer that does not extend into the muscle, bone, or tendons of the foot, is going to be the total contact test, or TCC, and this is a picture of us applying it. Basically, it decreases the pressure on the ulcer, and it's going to redistribute the weight over the entire foot, because the cast has essentially a bar at the base, a plaster fiber cut, and it has a plaster or fiberglass shell, and it can protect you have to protect the skin when you're doing the boot, and then you can leave the cast on for about a week or two. Usually at the beginning, we recommend that the patient come back to the clinic after about 3 or 4 days when we first apply it, and then we can leave it on for longer periods of time. So when do we recommend that a facility doesn't have a ProHealth 1 provider make a referral for these types of wounds? This would be for venous leg ulcers. This would be a patient that would want a procedure to assist in the healing of their venous leg ulcers, so an ablation or stripping or ligation. Patients that have venous leg ulcers that have not been improving after about 4 weeks of appropriate treatment. Patients with uncontrolled pain, so claudication and resting pain, which can indicate impending limb ischemia, and patients that have excessive bleeding. For arterial ulcers, these patients, usually when they get to us in the post-acute setting, they have been seen by a vascular surgeon or interventional cardiology or interventional radiology for some type of management. But if they haven't, it's important that they do see a vascular surgeon at some point. Also, we recommend that these patients see a vascular surgeon if the wound has an atypical appearance or atypical location, infected wounds, so wet gangrene, should go see a surgeon. Any suspicion of underlying osteomyelitis, so a bone infection. We also recommend that patients with uncontrolled pain, patients with absent pulses, and in general, patients with ABIs less than 0.9 should be in touch with a vascular surgeon for assisted in management of this disease. For diabetic foot ulcers, it's really important that they also have a podiatrist so that we can ensure that they have properly fitting shoes, so diabetic shoes. Podiatrists can also assist in issues regarding the foot structure. After longstanding diabetes and sensory neuropathy, the patient can start to develop what's called claw toes or hammer toes or sharklet's foot. Also, the toenails, podiatrists can assist in trimming the toenails and assisting with any ingrown toenails, fungus in toenails, deformities, or infections. Again, patients with diabetes, diabetic foot ulcers, and peripheral artery disease should be seen by a podiatrist and or a vascular surgeon. So in summary, if you have any patients with the lower extremity wounds, we recommend to get an ABI or a TBI so that we can not only clarify any questions with the etiology of the wounds, but in order to provide the appropriate treatment and intervention. So how can ProHealth One help you and your patients? So any provider or facility can order ABIs or TBIs through ProHealth One. It doesn't just have to be a patient with wounds. So primary care can order ABIs or TBIs. We have an ABI specialist, Wendy. She's great. So all we would need is an order, and you can send that via email. We would need is a face sheet, the type of exam that you're ordering, and any indication of current symptoms. And once the order is received, Wendy will reach out and schedule the exam. Another adjunctive treatment that we offer in our clinic is going to be VHT or vaporous hyperoxia therapy. VHT is a low-frequency, non-contact, non-thermal ultrasonic mist therapy that is combined with high-concentrated oxygen. It's FDA cleared and clinically validated as a safe and effective adjunct treatment for the healing of 9 types of ulcers. So DFUs, surgical sites after an amputation, venous leg ulcer, burns, gangrene, frostbite, skin grafts, post-surgical wounds, and pressure injury. And we offer this in our outpatient clinic. And some facilities as of late have VHT in their facility, and we are obviously happy to work with you and your team to provide treatment. This is actually a patient that I referred to the clinic for VHT. He had venous leg ulcers, and the patient on the picture on the left was the first outpatient clinic appointment on October 2023, and the picture on the right is January 2024 after receiving about 3 months of VHT treatment twice a week. In addition, we offer provider education. We provide education to ensure that your staff at the facilities is well trained in wound care and can lead to quick healing, reduced infection rates, and fewer complications. We have 3 grades, wound care certified registered nurses that can provide in-service training and in-service to your staff. That is CNAs, LPNs, RNs. They offer in-services in pressure injury prevention, wound care basics, dressings, wound application, etc. The next upcoming webinar is going to be May 7 regarding ostomy care, and then June 4th, wound care and legal compliance. And this is the contact information for our outpatient clinic, where we provide, in addition to wound care, total contact cast, Una boots, leg wraps, VHT, moleculite. We also provide ostomy care and education. On the bottom left is the information if you would like to order ABIs or TBIs. That's Wendy's email. And on the right is the phone number and email for our main offices. Thank you. If there's any questions, I'm happy to answer them. Oh, there's one. Two. Thanks. Thank you. Yeah, we're recording the presentation. We can send them out. All right, thank you. Okay, we will do that.